So Mr. Trench is a 65-year-old male who presents to the emergency department with chest discomfort. We put that in quotes because those were his own words that he used. This is an important note for like when you're documenting things. If they use a phrase like I'm having like a crushing pain in my chest, I usually like to put those in quotes because it's not really your clinical interpretation of what they mean. It's their own words, which I think can sometimes help in the way that we interpret their diagnosis, versus you calling it chest discomfort when their own words were chest pain or something like that. So that's just a little tidbit about note writing. It's something I like to do. It's something I was taught when I scribed. So this will go in the subjective part of the note. And we call this the chief complaint, would be chest discomfort. So what are some questions that we'd like to consider about his chest discomfort? What are some questions we might like to ask him, kind of about how to further characterize it? When did it start? He's been having it for a number of months. How often is a great question, Anna Maria. It kind of just comes and goes. And does it hurt when he breathes? Emily, this is a very, very good question about hurting when it breathes. When it breathes, that was an awful thing. When he breathes, did you ask that with anything specific in mind, or because that question can actually lead us to a number of things. Anna Maria, the how often is great, especially if, like Jonathan is saying, physical activity. Does it hurt more when he's climbing the stairs? We call that exertional chest pain. Jonathan, also past medical history is so important. Excellent question. Is there pain anywhere else? This could be like radiation down the arm. Bridget, taking any medication is great because that can point us to any comorbid conditions that he might have. Daily activity and diet, Jonathan, that's great. That's part of the social history. And it's something that a lot of clinicians actually neglect to ask. Emily said, not really. So it's actually a pretty advanced question about hurting when it breathes. That can be something as benign as a bleb in the lungs, or it can be pericarditis. So that's a really great question to ask. Always good to characterize the pain. Is it exertional? What makes it worse? What makes it better? Have you taken Tylenol? Destine asks, how would you describe the discomfort? That's a great question because crushing chest pain is different than a tearing chest pain. And as far as all of these questions, I have the answers on the slide coming up, but I just kind of wanted to see where everyone's head is at. And it seems like everybody here is super spot on. Describing the discomfort, I don't believe this patient is able to describe it any further. Except maybe he is, because I don't remember what I wrote. So the location of the pain is substernal. The sternum is is that hard part in the middle of your ribs that connects them in the middle. That was kind of redundant way of describing it on my part, but yep. So it's substernal, right in the middle. He describes it when asked as fluttering. Destine, to your question. Again, I put that in quotes because that's his word, not mine. It does not radiate. I believe Joshua asked if there's pain anywhere else. It's intermittent, it's non-exertional, not exacerbated by exercise, which is good. And it's been worsening over the last few months. I believe someone asked kind of how long did he have the pain for? So it's not acute onset, it's more chronic. So we might call this chronic substernal pain that he describes as fluttering without radiation. Associated symptoms, this kind of goes to Joshua's question about is there pain anywhere else? He's feeling a little nauseous and a little lightheaded. Do we need to pause? Are we okay to move on? Questions, comments, concerns? Good so far. Thanks, Stephanie. All right, I'm always happy to go back, especially at the end when everyone's trying to get their SOAP notes submitted. We can always go back at the end of the talk. I'll stick around. Okay. So now questions to consider about the patient in general. So this is not related to the chest discomfort. You guys hinted at this already. We asked about diet and physical activity. We asked about medications. We asked about past medical history. So those are all things we'll consider. So his past medical history is that he had a stroke in 2014. Do we need clarification on what a stroke is? I believe we had a session on we didn't have a session on a stroke. I believe maybe Emily did a session on, Emma did a session on strokes. If we need to clarify, let me know. But it left him with only partial use of his left hand. He also has hyperlipidemia and hypertension. Hyperlipidemia, anyone want to throw out what that means? And hypertension? Elevated lipids, yep, all right. You guys are way smarter than I was. So yep, hyperlipidemia, just meaning he's got like high cholesterol and he's got high blood pressure, exactly. His past surgical history, he had a hernia. I should have been more specific here. Basically just saying he's had surgery before, back in 2007. His dad had type 2 diabetes and his mother had hypothyroidism. I think I just threw that in for fun. That's not really relevant, which you'll see a lot of. Social history, he drinks 1 to 2 beers a night, 20 pack years smoker. Does anyone here know what pack year smoking is? I didn't learn this till med school, but if anyone knows what pack year smoking is, that'd be cool. And no illicit drug use, no heroin or cocaine or anything like that. I always get looks from people when I'm like, do you do cocaine? And they're like, what? And he takes lisinopril and atorvastatin. So this, atorvastatin, sorry. Lisinopril is for the blood pressure and the statin is for the lipidemia. So pack year smoking is a fun way to characterize it. So basically it's, if you smoke 1 pack a day, 20 packs for 20 years. Yes, Jonathan, you're exactly right. So that is one way to have a 20 pack year history. Another way to do it would be if I smoke 2 packs a day for 10 years, that would also be a 20 pack year history. So I've met patients who've had like a 200 pack year smoking history because they smoked like 10 packs of cigarettes a day. So it's kind of it's an interesting way to characterize it because it kind of shows severity. So it's not necessarily how many actual chronological years they've been smoking. It shows us like how many cigarettes really have they smoked relative to time. When did they find the time to breathe? I don't know. I don't know. This patient was like severely COPD. He was quite old. I also don't know where he found the funds. Things are expensive. So these are all still going to be going in the subjective bit of our case. Questions, comments, concerns? We can move on. I'm trying to get through the case a little bit quickly so we can spend more time on the fun part of this lecture. But any comments? Need me to slow down? All right. Pacing is good. Thanks, Stephanie. So differential. I don't even really know why I put these because this is obviously a heart lecture, but does anyone want to throw out some differentials for this guy's kind of substernal fluttering, chest discomfort, chronic, non-exertional? Bensari says AFib, which is excellent. We got myocarditis, which is also great. COPD, yeah, I think that this is great actually because of the 20 pack year smoking history, and we cannot exclude a lung pathology. I've been really leading you toward one thing. I've been anchoring on it, but you're right, we can't exclude it. COPD can also cause heart disease. Atrial flutter, Jonathan, this is great, which is related to but not the same as AFib, like Bansari said. Those are excellent. And those do classically present with kind of like a fluttering sensation in the chest. Anything else? When it comes to differentials, maybe a liver issue. Adam, why do you say liver issue? I like that. I like that we're thinking out of the box. Because classic thing that people miss, even in the hospital, is like, okay, I like where your head is at. People stick to one system and they forget that everything is touching. So alcohol consumption can lead to high output heart failure. So that's excellent. Liver issues may not cause fluttering necessarily on their own because the liver is a little far, but organs in the GI system, I like what you're thinking, that are close are like pancreas, stomach, like those are really close to where the heart is actually. So any of those pathologies could, but it's actually pretty advanced, the alcohol consumption, because that could definitely lead to high output heart failure. Stephanie says beer. Yeah. I mean, that can lead to arrhythmia, and we'll talk about that in a bit. Not beer. We'll talk about arrhythmia. Cirrhosis, yeah, also from the alcohol consumption. He drinks 1 to 2 beers a week, which is not too, it's not super concerning, but the technically correct answer is we should probably screen him and make sure it's not an issue. Anxiety or stress, Joshua, I like where your head is at. Yes, yes, anxiety and stress can cause heart palpitations. I had to wear a 48-hour heart monitor right before I took my MCAT because I was so stressed. I thought I was having a heart attack, but it was just stress and Red Bull. So here are the differentials that I put. Obviously, this could be expanded upon. We have arrhythmias. You guys mentioned a couple, AFib and atrial flutter and whatnot. We can have a premature ventricular contraction. If you've ever just been sitting and you feel your heart kind of like, it almost feels like you need to cough, like your heart kind of jumps for a second. That's actually a totally benign thing that happens to absolutely everyone, called a premature ventricular contraction. And these are super common. So that could be causing a fluttering sensation. I mentioned that the stomach is close. It could be GERD, especially if he's drinking a lot. Gastroesophageal reflux disease. Could be high blood pressure in the vessels connecting the heart to the lungs. Stephanie mentioned COPD. Could be pneumonia, but I mean, we haven't seen, I mean, he doesn't seem feverish or anything. Could be a buildup of fluid in the lungs. So now we'll take a look at his vitals. Now we've moved on now to the objective bit of the SOAP note. So he is afebrile, no fever. He's a little bit hypertensive, but that's consistent with his meds. We'd want to ask him, like, are you taking your meds consistently? Because it's a little high. He's a little, would we call this a normal heart rate? What would we call this? Anyone? Tachycardia. Perfect, Joshua. Well done. Yes, Adam. Yep, it's a little high. We'd like it to be between 60 and 100. Respiratory rate is a little high, but we're not super worried. O2 saturation, we'd like it to be a little higher. We're noticing here that he is on 2 liters of oxygen through nasal cannula, which are just those two little, the little tube that kind of runs under your nose with the little 2 nostril prong things. So he's getting oxygen and he's still satting a little low. But it's not too bad. So he's sitting up. He seems like he's in a little bit of distress. We palpated, or we kind of pressed on his chest, and there's no pain there. We listened to his lungs. Oops. Oh, I didn't know I could scroll like this with my mouse. His lungs were clear on both sides. There were no wheezes, rubs, or rhonchi. This is a classic thing that you'll find in documentation. Each of these kind of corresponds to different pathologies in the lungs, but this is not a lung lecture. So we won't go into it, but this is like a classic triad of things that you're going to say, like, there are none of these. In the heart, he is tachycardic, as was mentioned. He has an abnormal rhythm, meaning it's not regularly paced where there's like boom, 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 boom. It's going to sound like ba-da-da-da-da, da-da, da-da-da-da-da-da. Like it's kind of all over the place. Normal S1 and S2, we'll talk about that in a minute. No murmurs or rubs. Again, these correspond to pathologies in the heart. We'll talk about those. Any murmur that you hear in the heart means that there is turbulent flow along the valves. And we're going to talk about the valves in a minute. And no rubs. Rub literally means that the heart is rubbing on the fluid-filled sac that it sits in to protect it from the rest of the chest cavity. So if you literally can hear it rubbing, that's pericarditis, as was mentioned about kind of, is there pain when he breathes in, which is classic for pericarditis. Vascular, his pulses are 2+. This is normal, meaning his pulses aren't weak or unequal in his feet or his hands. We touched on his abdomen and it was soft, which is good. It was non-distended, meaning it wasn't like, there's no like fluid or obstruction that we could feel, and it didn't hurt when we pressed on his belly. Do we need to pause here? Can we move on? What is S1 and S2? Great question. We are going to talk about that in the remainder of the lecture. Don't worry. Any other questions? All right, I'll take that as a yes. What does 2+ mean? Okay, so 2+ is a scale that we use for pulses. And it's based, 2+ is basically like dead in the middle. So if it's like 4+ pulses, that means that the pulses are like too strong, which is indicative of certain pathologies. And if it's like 1+, then that means that the pulses are weak. So if you had unequal pulses, or like say you had a lot of blockages in the arteries that lead down to the feet, you might say pulses are 2+ in both of the wrists, but they're 1+ in both of the legs. And that would tell us as clinicians that, okay, so there must be something blocking the flow down to the legs. But 2+ in this case, dead in the middle, this is right where we want it to be. And it basically means that the pulses are normal. So I've done a session on EKGs before. We're not going to get too much into what each of these spikes mean because we're here to kind of even take a step back further from that. But the thing I want us to note here is that you'll notice that in a normal EKG, we have a little bump and then we have this big complex here, which is the heart muscle contracting. We're not really seeing any uniform bumps before these peaks, meaning that the heart is not really communicating well. And the other thing we look for is there equal spacing between each of these peaks? And what would you guys say? Is there equal spacing between each of these peaks here, if you were to track this bottom? No, exactly. So this is a classic EKG that will show up on every single one of your cardiac exams. This is called AFib. Someone hit the nail on the head earlier. AFib is classic for no discernible P waves, meaning we're not seeing the classic bump and then the complex. We're seeing a lot going on here, but we're not seeing the third one. Why or something? 1 second. We're not seeing any like a bump and then a complex, kind of a lot of noise. And then we're not seeing even, we call these R intervals because this top peak is the R. So this is AFib, which you're not responsible for knowing. I just think it's cool. So I had a question about why are some of the peaks going up and some of them going down? An EKG is an electrical snapshot of the heart. When we talk a little bit about the electrical, layout of the heart and kind of how electricity is conducted through it, I think it might make a little bit more sense. So basically, if the wave is going up, that means that the electrical signal is coming toward the probe. And if it's going down, that means the signal is going away from the probe. So it all has to do with where each of the stickers on the EKG leads are sitting relative to the heart and relative to like how the electrical wave is moving down the heart muscle in this down direction. It might make a little more sense once we look at the conduction system, but if it doesn't, let me know. And I'm happy to come back to this slide. So our assessment and plan, that EKG was diagnostic of AFib. So we're going to do ambulatory EKG, meaning we're going to keep him on a running EKG where we just keep getting a strip like that for a while because he's symptomatic. He's not feeling well. AFib is not a really terrible condition. A lot of people have it. A lot of times people have it and it kind of comes and goes. But this guy's symptomatic. He's feeling really poorly. So we're going to keep him in the hospital for a bit. He had a history of stroke. No one stopped me there, so I'm going to just assume that everyone's good with that. To look for clot formation with the bubble test, we're going to talk about both of these things in a minute. Don't worry. And we're going to start him on blood thinners. So I'm saying, don't worry. We will talk about all of these things and we will come full circle to this assessment and plan at the end. But I would just pop this into your assessment and plan for now. And someone let me know when you're ready for us to move into the fun part. Oh, you can also add like maybe alcohol counseling as like a 2. We should probably do that as well. And maybe we might even consider like adjusting his blood pressure medication since it's still kind of high, but that could also be from stress. Those are other things that you could add if you like. Are we ready to move on? Yes, awesome. Woo! Fun part. Okay, so in the heart, the way that this was described to me by a cardiologist is that when it comes to dealing with the heart, there's basically a plumber and there's an electrician, because there are two aspects to the heart. The heart is a glorified pump where blood flows in, and then from the lungs, from these pulmonary veins, so there's a lung here and there's a lung here, blood flows in, and then it gets pumped back out. We're going to talk about this in depth in a minute, so don't worry about this yet. But basically, blood flows in, and then it flows out, and then it comes back to be reoxygenated by the lungs. So that's the plumbing aspect. But then there's also the electrical aspect, which we talked about for briefly with the EKG electrical signal. We're going to talk about this also in depth. Starts here and then basically courses down the heart muscle in this downward direction to cause the heart muscle to contract upwards like this. So it kind of squeezes like a ball. But we're going to talk about this. This is just a basic overview that there's like two major aspects to how the heart works. So we're going to start by talking about the chambers. You guys can see, do you see my chat box? Is it blocking the screen? We see everything. Okay. Okay. Thank you. You can see the screen or you can see the chat box. Can you read the words on the screen? No chat box. Okay. Thank you, everyone. Sorry, I'm just making sure. Perfect. So can someone describe the structures oxygenated from blood from the lungs that will pass through the systemic circulation? So first, I'm going to start, well, if anyone wants to give it a shot, I've talked briefly about how there's a lung here that goes into the pulmonary vein, and there's a lung here that brings in blood from the other lung on the other side. Does anyone want to take a shot about the structures that blood will pass through to go from the lung into the systemic circulation? We got Emily saying left atrium and left ventricle. That's exactly right. So we're going to come in from this side, and what you can't see on the other side of the left atrium is there's also two little holes on the other side for each of these pulmonary veins. So there's 4 little holes in this atria. So blood will come in, it has oxygen, it goes down through the mitral valve here into the left ventricle, which is the strongest chamber of the heart. We can tell because the muscle here is the thickest, kind of like a guy who works out a lot or a girl who works out a lot and gets big muscles. This is the strongest contracting bit of the heart because it's most important that we pump blood out. It goes up through this aortic valve into the, you guessed it, the aorta. And then this aorta will supply blood to the entire body. Here we go up to the brain and the head. These will also shoot out to the arms here. And this will supply the abdomen and the lower limbs. So that is how oxygenated blood goes through. And if anyone wants to take a shot of how do we describe now the deoxygenated blood? So we've flowed out through the aorta, we've gone to the tissues and perfused them, they've offloaded all of their oxygen, and now we have to go back to the lungs to get oxygen again. What structures are we going to pass through? Anyone? Vena cava, perfect. So we have the superior vena cava and the inferior vena cava. This is coming from, again, the head and the arms. This is coming from the abdomen and the legs. And there are 2 holes, kind of like there were 4 holes in the left atrium. There are 2 holes, one for each of these in the right atrium, so that we come into this little chamber here. And you're absolutely right. Then we go into the right ventricle through the tricuspid valve into the right ventricle. And when the heart contracts up, not only is blood going to flow up this way, you can tell by the way the valves are going, is like, this is the way that the blood is flowing. So as the heart muscle pumps this way, can you see my mouse? Yes. Okay, perfect. When the heart muscle pumps up this way, blood is going to flow through 2 valves. Can anyone tell me which 2 valves those would be that the blood will flow through when the heart muscle contracts like this, in this direction, up? Or just one of the 2. Just take a shot. It's okay. Okay, Emily, you're exactly right. The mitral and the tricuspid will close because you'll notice these valves are all supposed to be one-way valves. So blood flow down through here. So when this muscle contracts, it like shuts these little doors here. So these valves close and blood will flow up through exactly like you guys are saying. It will flow up through the aortic valve and the pulmonary valve here into the lungs. So we are flowing out both oxygenated and deoxygenated blood at the same time when the muscle contracts. Now, when the muscle relaxes, which valves will open and which will close? Anyone? Tricuspid opens. Yep. And it's kind of, you can think of them like a little married couple. So these guys should be doing the same thing and these guys should be doing the same thing. And we know because they're kind of in the same direction here. So when this muscle it was contracted like a squished ball, and then the muscle retracts back to here, it relaxes. That opens these valves here because you can see they're kind of like, the valves are almost tethered to the bottom of the heart by these heartstrings. So when they say you're tugging at my heartstrings, that's real. We call them chordae tendineae. When this muscle relaxes, it literally pulls the valve open and deoxygenated blood will flow into the ventricle and simultaneously oxygenated blood will flow into the other ventricle. Is that starting to make sense? It's a tricky concept, but so it might take a couple passes, but does that kind of make sense? Yes. Okay, perfect. So someone asked earlier about the heart sounds. What are the heart sounds? You said S1, S2. It's confusing. So again, these valves are like a married couple. So S1 is the closing of the mitral and the tricuspid valve. So what has to happen? Will the muscle here be contracted or relaxed when those valves close? Contract. Perfect. So yeah, see, okay, so the heart is starting to make intuitive sense to you guys. So when this muscle contracts, we hear S1 because these two valves will close and these two valves here will open. Then when the muscle relaxes, we pull these valves open and these two will close, and that represents S2. Does that make sense? Perfect. So when we hear murmurs, that's because maybe there's a little calcification here on the valve. When the muscle relaxes and blood flows down through here, we're going to hear a little whooshing because it's not flowing laminarly down. It's kind of creating a little turbulence. And we can actually hear that as a murmur. So if someone says, I hear a heart murmur, that means that there's usually something structurally wrong with one of the valves. That's typically what that means. It represents turbulent flow. But if there's someone's talking about normal heart sounds, that is not the sound of the muscle contracting. That is the sound of the valves closing. Okay, so we're starting to put all these pieces together. You will see this chart again in your life, but we're gonna just break it down to what's important. We talked about this already. We call that muscle contracting systole. So systole is when the ventricles down here contract up, blood is pumped out of the heart, as we know, simultaneously to the aorta and to the pulmonary artery. Then diastole is when the muscle relaxes. This is when we hear S2, because blood is flowing back into the heart from both the lungs and from the IVC. So I think that this kind of helps it to make sense. Aortic valve closes here during S1, boom. I hope this all makes sense. It doesn't have to, you don't need to try to understand this chart just now. I know it's confusing, but I think if you can at least understand the way that the muscle contracts and relaxes and we hear the sounds, that's all that really matters here. What's happening? All right, so now I'm going to ask you guys a plumbing question because we've been talking about the plumbing aspect of the heart. So what happens when there is a heart attack Does anyone know how to describe kind of like what's going on pathologically when there's a heart attack? Like why does it happen? What does it mean? What's wrong with the heart? We can be as broad. Artery blockage. Yes, exactly. So we were talking about blood going through the aorta from the left ventricle here, but there's actually little offshoots from the aorta. The very first offshoots from the aorta create little tiny arteries that supply the muscle of the heart itself. So when there is a clot that goes into one of these arteries, it's usually this one here. This is the big guy. We call it the widowmaker or the LAD. This guy right here, say, can form a clot. And what happens to muscle? Well, so what would happen if we got a clot right here? What would happen to the rest of the tissue of the heart? Tissue death, exactly. So anything, if we get a blockage here, say, or even worse, up here, we call this a left main because this is the left and this is the left. If we get a big clot here, say, then all of this tissue down here and all of this tissue down here will not get oxygen. And what happens if the tissue doesn't get oxygen? What happens to the heart? Someone said tissue dies. That's correct. But what happens to the way it contracts? It stops beating or it doesn't beat as effectively. So when we have a heart attack, it makes it very difficult for this muscle to contract. So we're not going to be adequately pushing blood out. That's kind of why we can start to get some, like, you can feel lightheaded, you can feel dizzy, you can feel nauseous, you can feel tingling. You're not getting enough blood out, not in the right way. Exactly, Jaya. You cannot contract the muscle if it's not being supplied, which is why, here's the answer to the question: we stent if we can. If not, then you bring in a cardiac surgeon. But this is why when you come into the heart with a heart attack, so this phenomenon can happen in any of these arteries. These arteries here supply the entire heart muscle. So they're little tiny arteries that come off to supply the valves, to supply the wall, to supply the entire heart. It can happen to any artery, but statistically, the most common one is going to be here. And this will typically start to kill the ventricle down here, but it really can happen anywhere. It can affect any anatomic structure of the heart. Just as a tidbit. So anyway, so we stent, so we can thread up through, usually we go in through either the arm, meaning it would come in through like one of these big guys here into the aorta, and we would go down, or sometimes you'll see people go up through the femoral, and then we come up this way through the abdominal aorta, and then we can come down here through one of these little guys. So we're basically coming either this way or we're coming this way. So then we're coming down from the aorta up here. And then we can say we have our blockage right here. We can either come down here and stent, or we can come up through here and stent. And stenting is basically like we're putting in a little cage to just hold it open because it's been closed by like plaques usually. So when we saw this guy's history of hyperlipidemia or high cholesterol, that can lead to plaque buildup. And classically, it builds up right here in this left main artery here. So this is what it actually looks like when you're in what we call the cath lab or the catheter lab, cardiac catheterization lab. So you can see right here how this is supposed to connect in a line, but there's no flow. So we need to stent that open. So here, whoop, we brought in the wire. This is part of the wire here. We're going to throw a balloon in. Here you can see them inflating the balloon. This is the deflated balloon. This is the inflated balloon. We have fully expanded the little cage in there. And now when they add the dye back in again, you can see that we have fully restored flow in these arteries, and this saves lives. It takes minutes. And then if we can't fix it with the stent, then that's when you call in the cardiac surgeon to physically bypass. You would actually bring in a different artery and you would connect from, just to make it easy, like the aorta to like down here, and we're physically going to bypass this artery if we cannot stent it. I hope that makes sense. Does that make sense to everyone? Remember what my dad went? Stent or a bypass. Yeah, exactly. Yeah, no. So these stents are great. People can walk out the same day. They're really cool. Is bypass done by open heart surgery? Yes, it is. Isn't it usually the mammary artery? Mammary artery, yes, that's excellent that you said that. I actually just watched one of those today. We can take the mammary artery, which for those of you who don't know is like right, it's right on the inside of the chest next to the sternum. There's one on either side. And we can actually use those, and those would connect directly from the chest wall to down here. Super cool procedure. We used to take saphenous vein or something from the leg. So that's why sometimes you'll see heart patients who have their big sternotomy scar down the middle of their chest and one on their leg. But recent studies have shown that actually using those mammary arteries, which are already in the chest, can lead to even better outcomes. So that's the new thing. That's the new wave of what we're doing for, we call them cabbages or coronary artery bypass graftings. That's very astute. That's correct. And this is in fact an open heart procedure. But yeah, stenting is, if we can stent, let's stent. It's much better for the patient. It's better for everyone. How are stents inserted? So we will again thread kind of like a wire, either from the top, from the arms. We do radial artery a lot, which is in your wrist. Those people can usually walk out like hours after the stent is put in. You thread like a wire through, and then over the wire, you'll thread a deflated balloon that looks like this. So this is the wire that we would insert first so we can get in. Then over the wire, we thread like a deflated balloon with a cage around it. And then we push air into the balloon and it inflates the cage to hold it open. And then we deflate the balloon again and pull the whole thing out. So now we're going to talk about the electrical circuits in the heart, which is the other half of how the heart functions. So we have two major nodes. I keep going like this, down in this direction, because this is kind of the way the flow in the heart goes. And I talked about EKGs very briefly. So we start here in the sinoatrial node or the SA node. Just when in doubt, things go down into the left because we're looking at the patient's chest head on right now. So we start here. It goes down from here around like to the left atria and to the right atria to hit the AV node, which is right here. This is the second node. There are two nodes, sinoatrial, and you can remember that because it's like between the atria, which are these top bits again. And then we have the atrioventricular. So it's between the atria and the ventricles is the second node, AV node down here. So the signal will start here, go boop, down. So the signal goes down here, kind of like when you shock someone, or like if you've ever like gotten an electric shock or something for some bizarre reason, then it causes you to kind of like pull back and contract. That's kind of what happens to the heart. So the signal starts here. It kind of like shocks these parts of the atria. The atria contract and push blood again. When these chambers squeeze and get smaller, they're going to push blood down into these chambers. At the same time, the electrical signal is traveling down to the AV node. We go down through the bundle of His, and then it will kind of go up through these little Purkinje fibers, which are these last ones. There's these little guys here that go up through the ventricles. And so by the time the signal reaches down here, we already have fully filled chambers of blood because these chambers have already contracted and pushed all their blood into the ventricles. The ventricles will then contract and become smaller, and blood will flow out through the aorta and out through the pulmonary vein, pulmonary artery rather, which we cannot see in this diagram. It would be coming from this right ventricle out to the lungs. They have not showed it here. So I kind of just said it, but in case anyone is confused, does anyone want to describe what structures electricity flows through in the cardiac conduction system, just in order? SAAV bundle has Purkinje. Woo! Wonderful. Perfect. Okay, awesome. You guys understand it. So dysrhythmia, dys meaning like wrong or bad. Rhythmia is just the way that the rhythm of the heart is going. I didn't take Latin. Please, if you took Latin, I'm sorry if I'm saying the roots wrong. So basically, the rhythm is not correct. The limit does not exist. There is no correct rhythm. We have abnormal conduction of the heart. Some examples of this are going to be atrial fibrillation, which is what Mr. Trench had. Ventricular fibrillation. So not only can these top bits fibrillate, but also these bottom bits can fibrillate too, and that's actually way more dangerous. We can have heart block, which literally is like it sounds, the electrical signal as if electricity were water and it were flowing down like this. If there were a bridge here or like a what's the word? Like a block in the river. There's a word for that. It's escaping me. I'm sorry. And it were to stop here and it would block the signal, that's a heart block. So we can have that too. We won't get into it. It's kind of complicated, but any changes to this electrical system, blockages in it, pauses, weird circuits that are doing the wrong thing, that causes dysrhythmia. So does anyone want to take a stab at what's the best way to identify dysrhythmia? And there's actually a couple right answers here, but like, what are some of the ways? Bensare is correct. Yep, EKG is an excellent way to, and that would be my first choice, is an EKG, because this is literally a picture of, so someone had mentioned like V3 pointing up or pointing down. If you've ever seen an EKG, like on the chest, the leads kind of go all across the chest and like on the arms and on the feet. And so we're basically, you can think of each of those stickers as a camera pointed toward the heart. So every camera is taking a picture of the electricity, which is moving down in this direction from its own angle. So to like me up here, the electricity is moving away from me. But if I have a camera down here, the electricity is moving towards me. So if I'm down here, the peak would go up. But if I'm like up here, then the peak would go down, because it's moving away from me. Buzzsaw A-flutter. Yeah, we call that a sawtooth pattern. That's correct. So we can definitely see that if we had A-flutter on the EKG. We have a question about, would a heart attack be classified as a dysrhythmia? And this is a complicated question because it's not technically a dysrhythmia. We would call it an infarction or a blockage of the arteries. But these systems, I know I've been separating them into like plumbing versus electricity. They interact greatly. So if this muscle tissue were to die, guess what? These electrical signals don't work unless they're getting oxygen. So if this muscle starts to die and these bits, these Purkinje fibers can't get oxygen, this muscle is not going to contract because the tissue is dead and because the electricity is not flowing properly. And what did I say happens when the electricity doesn't flow properly? We can get dysrhythmia. So one of the reasons people actually die suddenly, or we have what's called sudden cardiac death, or why people die from heart attacks so quickly, is not because it was blocked and like the dead muscle killed them. It's actually usually because the muscle dies, the electrical system fails, and your heart stops pumping properly. It kind of like shakes and flutters and spasms. And then the blood can't come out, doesn't go to your brain, and you die. So that's actually why heart attacks are so deadly. Typically, the most common complication of a heart attack is an arrhythmia, which is why we're always going to look on those EKGs to make sure that you don't rapidly develop like VFib or something. Great question. So I can't even read what I wrote. What do we do when someone has an abnormal rhythm? There's a lot of answers to this question, but does anyone want to throw some stuff out? What are some of the things we can do if we identify an abnormal rhythm? Shock. Yep, we can shock them. Clear. Yeah, we can defibrillate them. Pacemaker, that's excellent. Shock them. Yep. And we can give drugs. That's absolutely right. We can give, if we have especially like a really slow heart rate. I really like that you mentioned this, Jonathan, because we can definitely give medications, and in fact, we do. A lot of people think that the only thing we can ever do is like just shock them. That's a great choice, but usually we use that in conjunction with medications. Epinephrine helps to kind of stimulate blood flow stimulate contraction. So if you have a sluggish heart, epinephrine will just kind of ramp up the heart's contractibility. So here are some things that we could do. I think you guys mentioned all of these. Some people will talk about cardioversion and defibrillation. I thought up until, this is embarrassing, I'm a third-year medical student right now. And up until like halfway through my first year, I was like using these two words interchangeably, which is really embarrassing for me. So they're not the same thing, but they are doing a similar thing, which is basically like you're trying to reset the electrical signal. If it's freaking out and fluttering and not quite doing the right thing, you can shock it to kind of like reset it. It's like plugging it in, it's like unplugging and replugging in your computer. Almost is kind of like what this does. You're like taking away electricity and then you're kind of like overdriving the electricity. So it just like starts from scratch, and that should work. So we're noticing like, we'll do this for VFib or VTAC, meaning ventricular tachycardia. So we talked about tachycardia as a fast heart rate. If the ventricles are pumping super, super, super fast, super deadly. So we will defibrillate then. Someone mentioned a pacemaker. We can implant a pacemaker right here in the chest. Leads will literally sit inside the heart, and they will send little pulses to basically stimulate the muscle to contract as if it were coming from one of the native nodes. So if we have what's called sick sinus syndrome, which sounds like it should be like an asthma condition, but it's actually a heart condition. We have this sinus node, sinoatrial node, and if that node gets sick, then it's not able to send signals all the way down the heart. So classic indication for a pacemaker is sick sinus syndrome. So you might see someone with a heart rate of like 40 or 30, and that could be sick sinus syndrome. It's just going to be like beating really sluggishly. This guy's not doing his job. Therefore, the heart's not contracting quickly. So then this will just kind of pick things up. And we can actually implant a defibrillator. So meaning if this device were to detect that the heart was in an abnormal rhythm, if we jumped into ventricular fibrillation or ventricular tachycardia, it would shock the heart from the inside. Shocking stops the heart. Yes, exactly. We're kind of overdriving the electrical system, so it like unplugs and replugs in the heart. So it just starts from scratch. Notably, question for the group, can we shock asystole? Can we shock a flat line? No. Okay, you guys are all ahead of the game. My biggest pet peeve in life is when people talk about like shocking a flat line. No, you cannot shock a rhythm if there is no rhythm. You cannot shock someone's heart back to life. So let's get back to the case now. We had a guy who, yeah, I know, it's always on TV shows and they're like, oh, he's flatlined, time to shock him. And I'm just like, don't you have like any medical professional on your staff? But it's more thrilling. So I get that it's fun to watch. I watch Grey's Anatomy, whatever. So back to the case, we're gonna get back to Mr. Trench. Now let's dissect why we have talked about all of this stuff. Ambulatory EKG. So why are we monitoring him? Why do we want him on continuous EKG? Anyone want to throw it out now that we've kind of talked about it? Any theories? I'll throw one out. So I mentioned very, very briefly, I understand if you missed it because I know I over talk, but okay, so we can check to see if the blood thinners are working. We'll talk about that in 1 second. That's a great point. But I mentioned that atrial fibrillation is actually pretty common and that it can come and go. So we might want to put him on ambulatory EKG or continuous EKG monitoring to see if the atrial fibrillation kind of resolves on its own, or if it develops into atrial fibrillation can kind of devolve into like a really dangerously fast heart rate, like above 200. And so we also would want to maybe monitor to see if it either like improves on its own or gets much, much worse. in which case we need to start pushing specific medications to slow down the heart. So that's why we might want to do that. We are going to give him an echocardiogram, which looks like this, which is I know the heart is upside down and flipped backwards. It's okay. We don't need to get into it just yet. But an echocardiogram, given his history of stroke, to look for clot formation. So how is stroke and atrial fibrillation? It's this atria that's fibrillating. Why are those two things related? Does anyone want to throw out a theory as to why it's related, that a stroke and a AFib? So clots, so it's kind of like a chicken and the egg thing, right? I mean, we have the clot can irritate the heart muscle and potentially cause it to contract abnormally. But when blood sits, like if you've ever cut yourself, your blood clots, right? It's sitting, it's interacting with oxygen. But also, like, if you were to like leave a pool of blood on the floor, this is a bad question because I don't know who's like sitting around looking at pools of blood. If you are, I'm a little worried for you. But the blood clots on its own. So static blood that isn't flowing through the chambers, the heart is a dynamic system, it clots. So if this chamber is fibrillating, meaning it's not contracting fully and squeezing and becoming small, but the wall is just kind of like shaking in place, just kind of like shivering almost, this muscle isn't contracting. So the blood in the atria is still. And when blood is still, it clots. And what's going to happen is if and when the atria does have a full contraction, those clots can travel down and up. And then I mentioned that these go to the arms. These also go to the brain. So if a little tiny clot that formed here because this atria is freaking out, those clots can go up to the brain and block the major vessels in the brain and cause stroke. Exactly. And some of you guys have said it while I was monologuing. But yes, so atrial fibrillation, especially if someone has like a stroke out of nowhere, a lot of times you want to consult with cardiology to do an echocardiogram like this to look to see if there's clots sitting in the heart. Maybe they have atrial fibrillation that comes and goes, and the clots are originating from the heart. So we need to start them on blood thinners so that we don't develop any more clots to decrease the risk of stroke. Also to decrease the risk of heart attack. Because as we saw when we talked about the heart attacks, little tiny arteries come off this way. Usually heart attacks are not from there because the blood is flowing so fast up through this aorta that usually the clots are going to go zoop, like right up, path of least resistance, because they kind of would have to go like down this way to get to the heart. So usually heart attacks are going to be from like cholesterol buildup in the arteries, but strokes certainly, because the blood's just going to go zoop straight up to the brain where it was already going and cause a stroke. So I talk about the bubble test, which is actually kind of complicated, but so basically we blow agitated saline or like kind of like a saltwater solution into one of the chambers of the heart. And if so like we notice that there are 4 chambers here, 1, 2, 3, 4. There are walls like this. There's a similar wall between the 2 atria. And if there's a hole there, then clots, like you might have heard of like a deep vein thrombosis or a DVT. Those form in the deep veins, not the arteries, the veins of the legs. So if we were to have a clot somewhere in the legs come up into the right atria, but we also had a hole between these 2 chambers, that clot can go up, across, down, and then back up and cause a stroke. I know that this is like a really wandering clot, but it can happen. So sometimes we will blow agitated water into this chamber to see if any of it, literally if any of those bubbles cross between these 2 chambers to see if there's a hole. And then we'll see, again, this is like if someone has a stroke and we want to know where the clots are coming from. If this atria is clean and there are no clots here, possibly they have clots in their legs that are traveling all the way around this way, the heart. Yes, DVTs can be a risk for pulmonary embolism, actually, for a much easier reason than if there was a hole between the ear. Pulmonary embolism is a clot forming in this artery here. And so, again, clots coming from the deep veins in the legs come up into the right atria, down to the tricuspid, into the right ventricle, up the pulmonary artery. And if they block here, deoxygenated blood does not get to the lungs. And that is a pulmonary embolism. So that concludes our case. We are 1 minute past the hour, but I am more than happy to stay and chat and answer any questions you have, to go back to slides that were confusing, or talk about anything having to do with hearts, cardiology, cardiac surgery, med school, whatever you want to talk about. I'm here as a resource. Can you go over the difference between AFib and aflutter? Yes, I can. I think it's a bit beyond the scope of this lecture. Can I go to the initial? Yes, I can. Basically, it's just a different way for, sorry, I can't do two things at once. It's a different way that basically the atria are not beating properly. And it has to do with the specific way that the rhythm is, or that the electricity is flowing through the heart. I think it's a little beyond the scope of the lecture. I think it requires a little bit of a deeper understanding of the conduction system. But basically in atrial fibrillation, the chambers are like not contracting. They're like kind of contracting in like a shiver. That's like non-uniform. So it's not, they're contracting in a non-uniform shiver basically. Because like, where's my EKG? Because you'll notice here that it's like, or where's a good strip? Like here we should see a P wave bump like this, and then a Q complex. But if you look here, like I don't see any P waves, I don't see any P waves, I don't see any P waves. Here I see kind of a bunch of mess. This looks a little like atrial flutter, but atrial flutter is going to look more like, they're going to be like more uniform bumps between, because it's kind of like the atria is contracting abnormally in a more uniform way. And typically in atrial flutter, we're going to see equal intervals between these QR complexes. So like the atria are like, it's fluttering abnormally, but it's still, the ventricles are still contracting in a way that is uniform. So it's a little confusing. Question 3 on the SOAP notes tells us to select 2 answers, but I'm unable. Okay. I hope you're able to still get it right. I will email Becca about that. Just pick one of the right answers in that case. I'm sorry about that. How does the change to step 1 to pass-fail affect residency if I have to go to an international medical school? Great question. I have a couple friends in Caribbean med schools who are asking themselves the same question. So the good news is there's more than one step. There's also step 2, which you'll have to score very high on because that still remains scored. And that can help to set you apart as long as you take it before you send your residency applications out. So I definitely recommend that to score high on step 2, which you'll take after you do your rotations. So I'm studying for that right now. And also, you're going to want to beef up other aspects of your application for residency, especially, unfortunately, if you're from an international school. Research is going to be really important. Getting some publications, poster presentations out there is going to be huge. And also, letters of recommendation are huge, making sure that you really impress during your rotations. I know many people at international med schools who are, say, at Caribbean schools, who are doing rotations in Miami, because I'm in Florida right now. So doing your away rotations in big hospitals in the US, getting letters from those US doctors and getting really, maybe even trying to publish with them and really getting high marks in your rotations is going to be vital. Class ranking, if your class ranks, will also be a factor. So you're just going to have to kind of focus on the other aspects of your application that will also contribute to your residency candidacy. I hope that makes sense, Jonathan. Tell me if it doesn't. So yeah. Again, I'm sorry about the one that says pick two and you can only pick one. Just pick one right answer and I will email Becca about that question and tell her to just give everyone full credit. Sorry about that. The ideal time to take the MCAT. So you definitely want to take it when you're ready, A. There's nothing wrong with delaying. Most people I know took it more than once. You want to take it so that you have your score in time to apply. So if you're planning to start submitting applications toward the end of the summer, then I would suggest taking your MCAT as long as you only plan on taking it once, like make sure your practice test scores are high. I would probably take it in like February or March. So that way you can get your score back in time to start submitting applications right when they open, which is what I always suggest people do. So that's probably what I would do. I'd think about when am I planning to apply, and let me time my test strategically. If you're one of those people who thinks, I don't know how I'm doing, I think I just want to take it, get a score, and if it's low, I'll retake it, so what? Then I would suggest taking it in like, if you want to apply again towards the end of the summer, say of next year, say I was thinking of applying this year, 2022 to med school. So I'm thinking, okay, so I want to have my stuff together by like maybe May, June, July. Then I would like to take my MCAT probably like now, later this month, especially if my test scores are like, I'll take it now, get my score back. Oof, it's a little low. I think I could do better. I'm going to grind out for another like month and a half. I'll take another one in March, and then I'll get my score back in time to like attach to my application. That's probably what I would do. I hope that makes sense. Tell me if it doesn't. You are welcome, everyone. I'm glad that everyone enjoyed this lecture. Some people have requested it. So I believe I'm doing another lecture in like a week or two about, and that's going to be more surgery. Unfortunately, it's not heart, on postoperative fever, which is huge. So we'll get to kind of talk about surgery a little, which should be really exciting. So yeah, I think that would be fun. College admission, you mean to the medical college? So it depends. So once you submit your application, which I always suggest you do as soon as it opens. I'm not sure what the date is for this year yet. Usually towards the end of the summer, people start getting interview requests as early as like September, October. And I know that I had an interview around that time and I got an acceptance like 2 weeks later. But I also know people who interviewed in like February, March, April, and then didn't get an acceptance till June, like weeks before school started. So really an acceptance can come anytime from like after your first interview, which again can happen very soon after you send your application, which is why I always suggest you send your stuff out as soon as you can. I would send it out as soon as they open, have everything ready, have your essays ready, because as soon as you submit your primary, your secondaries will start trickling in, and you need to pound those out as quickly as you can, as long as the quality is high, as quickly as you can without like burning yourself out and they become low quality. So primary should go out right out the gate. Secondaries come back, get those out. I always try to get people to do a turnaround like within a month if you can, shorter if you're able. And then just fill those out, and then you just kind of sit and you wait and you use your coping and relaxation strategies and wait for the interviews to come in. I think I cried every day for like a month because I was so stressed that I wasn't going to get any interviews. And that's okay if you do that. That doesn't mean you're unstable. That just means that you care a lot. That's what I tell myself. So it's fine. You just kind of wait, you interview, and again, those results can come back 2 weeks after your interview. They can come back months after your interview, and you can get a wait list, a rejection, or an acceptance. So it really varies far too much, I think, but I hope that helps. Again, I'm so happy to see everyone. Do you have any advice for someone who wasn't a pre-med major and how to stand out? Yeah, I mean, there's a bunch of people in my class who weren't pre-med majors. I know my college that I went to didn't even have a pre-med major. I studied biochem. So you don't need to be a pre-med major. I think good ways to stand out to med schools is clinical exposure. I always recommend scribing over shadowing because it's like shadowing, but you're actually interacting with patients. You have responsibilities. Often it's paid. You learn the jargon. You'll be one step ahead of your classmates once you start learning how to write notes. I scribed. It was invaluable. Every interview I went on asked about it. So scribing is great, or really any type of clinical exposure is great. So if you work as an MA, a couple of my classmates did that. Volunteering is great. A lot of applicants that I've seen volunteered in hospitals. Also, so you can volunteer, you can shadow. Shadowing is always good. And I always recommend scribing. I think that really makes you stand apart. And if you can scribe in an emergency department, pro tip, you see like the most variety of cases, because I feel like if you scribe for a specific office, you're going to get a lot of exposure to one thing, which is great because you'll probably get a letter from them, and you should if you scribe or volunteer with some, or not volunteer, but if you scribe with someone, or if you shadow someone who knows you really well, like a letter from them will look great. Don't underestimate the power of a good letter, especially from a clinician. Then I think that will really help you to stand apart. Also, publications, doing research in undergraduate is big, but not essential. You don't need to have done research. Many of my classmates did not do any research at all. But I think it's always encouraged to do research. Definitely try to get some clinical exposure. Any sort of work experience. Medical schools like to see kind of the like responsibility, accountability, like ability to kind of work and have a job. So any type of like job experience is always really good for them to see. And then also like med schools get a lot of the same like bio major, high GPA, high MCAT, volunteered, shadowed, whatever. Like we all look pretty similar on paper, unfortunately. So also life experiences like sports you played, instruments, really cool, enriching trips that you took, unique hobbies, like talking about those things too, add personality, show that you like have a life outside of medicine. Like if you become stressed, you have somewhere to go that isn't a textbook. So kind of being able to demonstrate also the things about you that aren't necessarily medical, quote unquote. I mean, I wouldn't spend my whole application talking about them, but I mean, I talked a lot about like a sports team that I was on that really impacted my life. And most of my personal statement had to do with that. So I think that I don't know if I've completely gone off the rails here, but I hope that makes sense. So far from, yeah. I mean, I know business majors who are in med school. I know people who were out for 10 years from college who are med students now in their 30s. So, and I think the fact that you were a former teacher, play that up. That's huge. Like working, much of medical school is about teaching. I mean, I'm here right now talking to you guys because I love to teach. I love to talk. Residency is one great big teaching program. So you're going to spend the rest of your, not the rest of your medical career, but at least the next few years having to know how to like teach yourself, teach your classmates, teach the people in the years below you. And also teach your med students when you're a resident. So play that up, that's huge. And I think that the fact you're not a pre-med major, you know, it's certainly not a weakness. It might even be a strength, depending on how you put it. And the fact that you're scribing is amazing. Geriatrics is cool. I really like geriatrics. I'm so happy for you guys who enjoyed this session. I also work for Motivate MD. I do applications, I do editing. So you can always ask if I can edit stuff, or if you want to hop on Zoom and talk about stuff or about your application. I'm more than happy to sit down and chat. My name's Jackie. If you ever want to just talk. Any other questions? Awesome. All right. So it sounds like everybody's pretty much gotten their questions addressed. So I'm going to sign off, which means the meeting is going to end. But thank you all so much for being here. And I hope to see you guys at the post-op fever lecture in a week or two. I think it's in 2 weeks. So I hope to see you guys there. Happy New Year to everyone. Hopefully I talk to you soon. Bye.